All right, everyone, we're going to get started with today's meeting. Good afternoon, everyone. Welcome to the February 13th meeting of the Non-Controlled Prescription Drugs Workgroup. My name is Anna Gribble. I am a program manager here with the Maryland Healthcare Commission and the Center for Health Information Technology and Innovative Care Delivery. We will not be taking a formal roll call today. Instead, we ask participants to please update your name in Zoom by selecting the three dots in the top right corner of your image or name and indicate your organization. As well as please indicate which organization you're representing when you begin speaking during the discussion portion of today's call. This meeting is being recorded and a copy of the recording will be posted on MHCC's webpage. I have on the screen the agenda for today's meeting, but before we move forward, I invite David Sharp or Ben Steffen to make any opening remarks they may have to the group today.
Thank you, Anna, and welcome everyone. Our executive director, Mr. Steffen, will probably join us with the meeting in progress today. Thank you all for taking time to speak with us in this next hour. So I'm not going to make any other additional remarks and just invite you all to go ahead and get started. Anna.
Thanks, Dave. So for today's meeting, we intend to discuss the risks and benefits associated with reporting of non-controlled or non-CDS dispense data to CRISP, as well as identify and deliberate on consumer privacy issues pertaining to the reporting of dispense information, and consider technical approaches for consumers to opt out of sharing their dispense information. So with that, we have a few discussion questions prepared for today's call. And for our first discussion question for the group, what is the value of enabling healthcare providers to have access to complete medication records? Along those lines, what are the risks associated with care delivery when medication records are incomplete?
And Anna, if you'll indulge me, I would like to invite Dr. Morheim to make some remarks here.
Thank you. Thank you, Anna. Thank you, David. And thanks everybody for being here. I think the best answer is to look at the bill hearing from the 2022 session and read my testimony and Ben Steffen testimony. And it really is the nature of clinical practice. You've got to know what people are taking and you can't guess. It used to be you could sort of guess. I'll give you a very simple example. Many years ago, someone was on an anticoagulant. It was either aspirin or Coumadin. You could say, are you taking aspirin? They would know yes or no. If not, it was the other one. And working in an emergency room in a level 2 trauma center for 25 years, occasionally we would have to think about reversing anticoagulation in order to treat hemorrhage. Well, now there's many categories you can't guess. Likewise for diabetes medicine and so on. But I think really a good summary is in the go to the bill from 2022 session. Click on it. It says witness list. There's quite a few witnesses all in favor. Scroll down and read Ben Steffen's and mine. And the number, I think Ben makes the point, and then I'll stop talking, which is 6, 8, 10% of hospital admissions are medication related. If we can reduce that by half by having clinicians being able to have access to national, not just local, national non-CDS information that's real time, not days or hours old, that it's accurate, and that's readily accessible in the electronic health record, then we'll go a long way to helping folks and reducing costs. Thanks, David.
You're quite welcome. Thank you, Dr. Morheim. We have a couple other physicians, so why don't we see if there's any other additional comments to build on what Dr. Morheim had just said.
I would like to add something to what Dr. Morheim said. And oh, sorry about my background. I was in a glass. I make these things out of glass, and so I was showing my another group. So I'll change it after when make it look more professional. But
No
anyway,
worries. Very nice looking though.
I have no artistic skill whatsoever. But what Dan said is very critical in your first encounter with the patient. But I'm a cancer surgeon and a gynecologic oncologist, so it's as critical for those of us that that are subspecialists. So we see patients in OBGYN. We are more likely to be, associated with primary care of the patient, but in in the vast majority of cases, by the time you get down to an oncologist, that patient has already seen their cardiologist, an anesthesiologist, a generalist, and other specialists. And, you know, in my case, because I'm an OBGYN provider in, you know, my basic board certification is an OBGYN, you know, we have to be concerned also about teratogens. What medications are people on that could result in birth defects, or that could cause things like, you know, some really horrible side effects of some of the treatments that we provide. So I'll give you an example of that, and that is, you know, the acne creams that people use that have tetracycline derivatives, or if some or Accutane, for example. But Accutane is a well-known, and retinoic acids are well-known teratogens. I have to know that a dermatologist has put a patient on that medication, and the patient has to know what it is. And one of the worst radiation burns that I had in a patient, it wasn't even my patient, but one of the worst radiation burns I saw was it was an intersex patient who had anal cancer and was treated with primarily with radiation and some chemotherapy. And she came to me, and she had been on a tetracycline cream for her face that was not reported. And she didn't know. I had to, you know, she dug it out of her bag, and I looked at it, and it had tetracycline in it, and she was radiated, and this florid radiation burn that was, you know, extremely unusual, but I had to treat that for several months. And so, you know, you can see that not knowing, and the patient, you can't put the onus on the patient to necessarily know that something as simple as an acne cream might be something that would result in this kind of side effect. So those are things that you know, kind of stay in your mind, and you'll never ever forget how important it is to know every medication and even supplement that a patient's on.
Thank you, Dr. McCree. We have a number of pharmacists on the line today. Perhaps we could get a few folks to weigh in, and then we want to hear from some consumers. Dr. Evans, can I invite you to the conversation? Okay.
Sorry about that. I was on mute. Thank you for the promotion. I'm not a doctor. I am a registered pharmacist. I've been at this a long time. I agree with what has been said, and the specific examples are sometimes frightening. If we don't have access to the patient's profile, it is very difficult to perform DUR, to warn prescribers about potential drug interactions, or to warn patients about certain actions they should take if they're taking medications together. And so I really don't have anything other to add.
Well, thank you, Bill. Rebecca Wilcox, any thoughts from your perspective?
Hi, good afternoon. I am not a pharmacist. I was a pharmacy tech for many years. I don't really have anything to add from Walgreens' perspective, no.
Okay, thank you. Any other pharmacists on the line wish to make a comment?
David, Dan Morheim again, just to quickly add that, of course, patients go to different places for care, and they may have different prescriptions from different places. And so not, you know, whoever is the clinician, especially in my setting, the ER, you really need to have the full list. But we've all seen the situation where patients bring in a bag of pills, and then we lay them out on the table and try to sort it out. It really needs to be accurate and up to date.
Yeah.
Sometimes nobody really has the overview of everything that's going on with a single person.
Yeah, thank you, Dr. Morheim. So why don't we invite some of the consumers to share their perspectives? I think we have Robin Elliott on the call today.
Hi, David. So not going to sort of mostly just listening. I know this group has been meeting, and since this is my first time being invited, just kind of absorbing the scope of your work. Just wanted to flag that there are situations where patients and consumers have good reason to be afraid if their prescription data is shared. We're facing some very seeing some very troubling trends in this country in terms of banning care, making things illegal. So we're looking forward to working with this group.
Okay, thank you, Robin. Yeah, I think we have Kate Fahrenholt from NAMI. Kate, are you with us today?
Yeah, sorry, I got in a little bit late, and I just appreciate the invitation. I also, like Robin, I'm a little bit fresh to this. Certainly in the psychiatric space, there's certainly a lot of stigma and all that, but and I do understand Robin's concerns about our political climate right now. On the other hand, many of our core stakeholders and their families end up getting treatment at a variety of different places when they're in crisis or moving around, and not having, and thank you, Dan, I just came in at the tail end of your comments, not having accurate, preferably as close to real time, but certainly accurate information about the range of medications that the person has been on is just absolutely essential. But yes, confidentiality and all of that is so important. And that's all I have to say right now, but I will be listening. And I did want to mention, I did say this to someone, Anna, that to the extent you have a little bit of time here, we have about 58,000 people on our in our database, and we can certainly send out a short survey to find out people's direct response. And some stories if you need them. So let us know. Thanks.
Oh, very good. Thank you very much, Kate. And Jim, your thoughts?
Again, from a personal perspective, since AARP has not taken a position on these issues, privacy of data is an important issue, and the protection of it is important. It does not trump safety, but somehow we got to make these two work together. That's all I got for now.
Yeah, no, that's a very good point. And I don't believe we have Margot. Margot, are you here? I don't see you listed, but I could be incorrect. Okay, I think there was a comment. Let's just see if it's Leanne, do you want to articulate your comment for the group? You may be on mute.
This is Leanne Lewis with Scenario. And the question I had is, I know that there are certain regulations in the states that will require, even if it's an out-of-state pharmacy, that they have to report controlled substances within the PDMP program. But is that same in place if some of the specialized pharmacies that don't dispense controlled substances, do they have to report to the state?
So thank you for the question. So what we're looking at is implementing the requirements that were passed in the legislation, requiring non-controlled dispensed drugs to be reported by dispensers in the state. And what we've been talking about heretofore has been what are the technical specifications, and in today's discussion, we've turned it a little bit towards the privacy component and wanted to hear any concerns that were expressed. So, so the short answer is, yeah, that's where we're headed for, because that's what the legislation requires. But that said, there are also the areas of exemptions. There's also the areas that we're hearing, that we'd hear from consumers about protections. So there's a lot of dimension to be considered. And today we're wanting to get an understanding of what some of those might be and help us in terms of how we proceed. So why don't I ask Maya to talk a little bit about what exists today with consent, at least through the state designated HIE, how consumers opt in and opt out. And then perhaps we could hear a little bit from some of the physicians about, you know, what that means to them when they're at the bedside. Maya, can you talk about how consumers would approach the opt-in, opt-out today?
Sure. So I'm from CRISP for all of our new folks. I'm a senior program manager and I work on the PDMP as well as some other things. So consent is not an opt-out, is not my area of expertise, but I will do my best. Right now, it's fairly simple. Patients can go to our website and simply click opt-out and give information to us via an electronic form. Right now, the only options are to opt out of sharing all of your information. And this excludes the PDMP because the PDMP is required to be collected, but all other information will not be collected. And then you can opt out of research specifically. So those are the two options right now. I'm also aware that our attorney, Nicole Sweeney, is working on kind of a process to think about how we might do more granular opt-outs. And I think we're working from the technical side as to see how that could possibly be possible. So that's a quick overview. If there are any questions.
Okay, thank you, Maya. Any questions for the group for Maya? So I think to summarize, today in the current state, for not just CRISP, but for other HIEs that are operating in Maryland, it is a situation where a consumer, if they did not want their information shared, and this would apply as well for non-CDS, they would have to opt out of information sharing through the HIE. What we're looking at, I think Maya touched on briefly, is a more granular process that in time would allow consumers to have control through granularity. The actual, what does that look like and how it might work? It's just way too early, I think, to have a good sense to even be able to share that. There are a couple approaches that could be considered. Theoretically, you could look at it at an NDC level, and we know there are lots of challenges with that because there's the NDCs for generic and non-generic. There's the NDC there's the codes that are used by packaging of it, and we also know that certain drugs, while used in instances where consumers may wish to protect, are also used in other situations that, what I'll say for lack of general terminology, is less stigmatizing. So there's lots of challenges when you think through on the medication itself. There's also on the provider, specific physician or healthcare provider that does the prescribing. And that's another avenue for consideration. It probably has as many strengths and weaknesses as reporting on medication. But on the surface, the implementation of it may be less onerous if you're thinking of it from a technology standpoint. But there still may be other pathways, a hybrid model that could be thought about. In the short term, however, it appears that the best approach, if you're not wishing to have your information shared, is via the opt-out approach, because there doesn't seem to be a stopgap yet ready to implement. I could be wrong. I don't want to speak for CRISP entirely. I think Maya did a great job sort of characterizing it, but we need to have some more discussions to really figure this out. So I think that's a fair assertion. So I would ask the group if there's any questions or comments as it relates to information sharing based upon what you've heard Maya share and at the same time what I've presented to you.
It looks like Margaret, you have your hand raised.
Yes, Margaret Johnson with Transaction Data Systems. We're a pharmacy software vendor. Speaking in terms of the ASAP, which we had talked about being able to upload, it'd be very difficult for a pharmacy software to pick out certain drugs or prescriptions to not upload. So would that be something that we would still upload to CRISP, and then CRISP look at the level of what the patient does or doesn't want shared from that point on?
So the short answer is it's TBD, but on the surface, it sounds like that's exactly right. Because if this approach were pursued, and it would be more at a medication level, I don't imagine that would be a function that would be tasked to the dispensers. It would probably occur more at the technical infrastructure level of the HIE or the vendor who's doing this work.
Okay, thank you.
Good question. Perhaps Dr. Macri can talk a little bit about the challenges of reporting at a drug level.
Okay, I'm a surgeon, but I'm having trouble unmuting. So I lost the last thing that you were saying. I was tracking though, and I do want to make a comment, and that is that there's a couple of things that I think that for the HIEs and also for pharmacies, is that number one, we actually do have to make sure that that the patient standing in front of us is the patient for whom these drugs are actually attributable, right? So if you look at some systems, you have to make sure that let's say it's a medium level name, like Michael Sullivan. That's not a hugely uncommon name, but it's not extremely common either, depending on where you live. And if there's 4 choices in my EHR, as there used to be, if I pick the wrong one, it's a violation, right? So there's that risk. So you have to make sure that so the identity resolution is probably pretty important as well. And then if the consumer, so I'm looking at that RFP, actually, David. So if the consumer wants to opt out, we obviously already have our the company I work for now, already has over 260 million Americans in our database. And if the consumer, if you can, which we could create a registry of the consumer's preferences, that would be kind of ideal. But the question is, if that information is inadvertently shared or purposely shared, you need a way to tag it. And we've been, working with this as well. And so, if you can advance into the blockchain arena, then you can actually identify who has touched that packet of data and who was the last person to pack it. And then that way the consumer can be more sure that the person that, there's a set number of people who could have shared that that HIPAA protected information. And so working that into a national system, I think would be key to giving the consumer more confidence that that the information shared is shared on a verifiable need to know basis, and not on one where an employer, obviously in the military, we're very concerned about if an employer knows that we're on certain drugs, as somebody alluded to earlier with regard to psychoactive drugs and or depression drugs, right? So therefore, that's I think one thing, David, that I've been thinking about a lot in the last week or so with regard to information sharing. But the Support Act and the Mission Act from 2018 both do say in law, that's signed into law, that information blocking, so that the action of purposely information blocking, when you know that that's that there is a way to securely share information, but you're purposely blocking it for whatever reason, is actually against the law. So we can also fall back on the written law from the Support and the Mission Acts. And then in the terms of those of us that are veterans, we do have that issue of not being able to share information between the VA and the community care providers.
And you mentioned interesting technology. It may be foreign to a lot of folks on the call about blockchain. So that's probably a full discussion meeting in itself. But do you know of where blockchain is being used in healthcare today? It's predominantly used in the financial markets.
Right, and so healthcare is, so if you look at it as a parallel, there's not really a reason not to use it, right? And actually, people younger and smarter than I in my company are the ones that really know how to do this. I'm like, I just had a Medicare birthday, David. And so, I came from the no cell phone era, but the point is that, your financial transactions are really, people want that to be private. But there's no reason not to view healthcare data in this as of the same value as actually your dollars. And so if you use if you can imagine the blockchain, and if I can imagine it, then anybody else on this call can too. I'm not that smart, and I can tell you that, but I can tell you that being able to identify who the last person who touched that packet of information can give may give the consumer a little bit more confidence in allowing information to be shared among the need to know individuals or entities.
And so I suppose that's about right. I guess I would just ask Robin, is that really is it the last person who touched it? Or
no, it's any, it records the hash. There's a hash for everybody who has touched it, but everybody is identified on that packet of information as somebody who has touched that information. And so, you have to be careful about whose information you touch. And that's why identity resolution to the, 100% or 99.9% is so important, because if I click on the wrong Michael Sullivan, right, I've touched that person's package, even if it wasn't my patient and I didn't intend to. Right. But if I get a pick list, from the EHR or from the, anywhere, I get to pick which one I want. And that could lead to, some errors. And I think if we can get a better way to identify the individual for whom those prescriptions are written, to whom those prescriptions are dispensed, and to whom the diagnosis is given, right? That one individual without any potential for error, then we have a much more secure system.
Sure. So
David, Dan Morheim again, just, for those who are looking in the chat, I don't want to, overload it, but that's the value proposition in the chat, quoting a number of articles, testimony, source material as to why this is important. So I appreciate all the hiccups and the concerns, that work that's going to have to be done to make it work, but it's really worthwhile to make it work, is the point. And all the points should be considered. They're all legitimate, but that shouldn't prevent us from getting at least something substantial done as soon as possible. And there's articles, and I just picked a few just right off the bat, and there's many more.
Right. Well, and Dr. Morheim, to your point, I think the short term, as soon as possible, is the opt-in or opt-out, which is available today. I think
that would be a good start. That would be something. Well, in the ER again, we'll take any piece of information we can get, and we're also skeptical about all the information we get. But as pointed out, in this last article, 15% of hospital admissions, drug-related problems. I'm surprised it's that high, but that's it. And ERs are 60 to 95% of hospital admissions. So, You know, if we get something, that's better than nothing. Just like getting the PDMP is helpful, but it may not have somebody from Oregon in it, but at least it's something. And so if it's an opt-out and it's comprehensive till CRISP and you can figure out another ways to do it, great, that's a start.
And so, thank you, Dr. Mohan. The question, Robin, is if you could clarify for the group, and this is more a matter of what you think, it's anecdotal, I suppose. Is the concern of consumers largely focusing on misuse of information, or is the fear that, you know, if it's sent to this physician, it could in some way disadvantage a consumer, or is it the third choice? Is it the fear that it just could get more broadly on the, you know, shared outside of that physician treatment relationship, which would cause consternation to consumers?
So I think there are probably several groups of issues. I'll just focus on two groups right now. I think there is some genuine public health concern that consumers' need for confidentiality can be very paramount. And if they fear that information about their services or their medication will be disclosed, they may not seek it in the first place. And there's some research around that, particularly related to adolescents and STIs. And then the second is really, we are facing right now a very real legal issue where people and providers are looking at being criminalized for care that they provide in Maryland that's legal here and is illegal in other states. And so that's a unique situation. It didn't actually, wasn't around when the bill went through, but it's where we are today. So, and it's very unfortunate, but it's the reality of something we have to worry about.
Very good points. Very good points. Thank you, Rob, and others.
And, you know, to follow on with that, Robin, because I am, as I mentioned, I'm a OBGYN doctor. And so some of the drugs that they're trying to ban are actually have other uses. So just because I write a prescription for mifepristone or for misoprostol, right, or both, doesn't mean that I'm doing any medical, I'm writing for medical abortions. It may mean that I'm using it for cervical ripening or for something else. You know what I mean? But yet, if that information got out, both myself and the person for whom the prescription is written may be targeted. And, you know, the $3.5 million that's been released by the governor, I don't know if there is enough money in there for security. So those are other considerations for pharmacies and for providers, not the least of whom, I mean, not only for patients.
Dan, again, Robin, you make an excellent point, and I completely agree with you. I think there is some pending legislation about not sharing that kind of information or something like that. You're more on top of pending legislation than I am, but there is some legislation that moves in that direction, and maybe that's an amendment to that kind of legislation that might be of service to the point you're making, which I agree with.
Yeah, thank you, Dr. Morheim. And there is pending legislation trying to get at this issue. And so today's discussion is really timely.
Yeah, and so
that I'm on the MedChi Legislative Committee, and I think we're going to be approving that officially this evening.
Thank you.
So with the technology constraints that exist at the moment, I'm just trying to think that through, because I think what Rob and Dr. Morheim you're noting in the legislation is specific at the medication level. Is that correct? And I believe that's correct.
I don't know. Maybe Robin does. I don't know that.
It's both services and medication, because there's, and this is obviously kind of beyond the scope of this specific work group, but you do also have information about services that go over state lines on health information exchanges. I would say the concern specifically about medication abortion affects both out of state, that's clearly at risk if the patient or the consumer ends up going, to another provider in Texas. But the risk also exists within the state because being able to identify providers of reproductive health care or gender affirming care is another issue, not tackled by the legislation pending, but is something really to think about. Just being able to be identified could put that provider at risk in today's climate. So, and I'm very, very happy to chat with anyone about this and take ideas. It's definitely new territory. Not sure quite, David, as you pointed out, technologically how to do this, but just know that there's an urgent need to at least come up with some way to address it as soon as possible. And maybe it's an initial fix, and we have to look at kind of a longer term fix, but we just know people are at risk right now.
So, there's never one answer, and I'm not sure there's ever the air quote right answer. I think, as you've noted, it's oftentimes how one characterizes a good start, and then you build on it. I was wondering, because what comes to mind is, and Anna, maybe you could talk a little bit about your experience with the PDMP, because I believe, much like we heard, and I forget who mentioned it early on, that would it be the vendor that could, if there was a type of drug or classification of drugs, to what I hear, Robin and perhaps Dr. McCree saying, it's not perfect, but if the vendor were able to block that from information sharing, might that accomplish, and I say the vendor, meaning they would receive it from the dispensers and then block it. Is that very similar to how the PDMP works or has worked in the past?
Yeah, I can share a little bit, and then Sarah can jump in for what I missed. Recently, the Maryland PDMP started collecting naloxone dispenses specifically, and this is in line with about 22 other states that collect naloxone dispenses within their prescription drug monitoring program. And that data is currently collected by a vendor that's been shared with Chris, and then based on a list of NDC codes, that naloxone information is suppressed from being shared in the clinical view. And that information is then available for public health purposes to target more informed naloxone distribution efforts at the local level potentially, but it's only available in aggregate, say the number of naloxone dispenses that occurred within a region of the state. Maya or Sarah, do you have anything you want to add to that process and that it's something newer that the PDMP has started doing?
Yes, so we haven't officially started collecting naloxone dispenses yet. Today's the last day of our regulations being posted for comment, so we're excited about that. Anyway, it seems like it's a little bit easier for us because by statute, we're going to start to collect naloxone, but it's a non-CDS. So it's pretty easy to separate out from our CDS dispenses in regard to allowing them to be viewable by clinicians, because our statute for naloxone does not allow clinical use of this data. So we show controlled substances to our users, and it's easy to filter out the non-CDS. In fact, we get non-CDS dispenses uploaded to us occasionally anyway. So again, but we don't allow those to be viewed in the clinical view or in any view. The naloxone dispenses will be able to be used by public health officials for surveillance. So when I've talked with dispensers about you know, how easy is it going to be to just start uploading naloxone dispenses to us? I haven't heard any barriers. So, but again, our situation's a little easier because it's a non-CDS. You guys would be separating non-CDS from non-CDS and suppressing them or filtering them.
Yeah, and Sarah, just to add to that, you know, the way we know it's a non-CDS is by the schedule. We only collect certain scheduled drugs.
Right.
And so this would be filtered, for example, by NDC, which indicates the exact drug. And as you say, it's much more complicated to go through a list of the, I don't know, tens or hundreds of thousands of NDCs and determine which one should or shouldn't be included. And as I mentioned before, I think some of that work is already in progress to think about some of the potentially sensitive drugs. So I know that this is definitely an issue that CRISP and the state is aware of and working on in general.
Well, and I'm also wondering, you guys were talking about sharing this information with other states. So for the PDMP, there's 2 data sharing hubs, and we have agreements with other states who use these hubs when we share CDS dispenses with other states. I don't know if there's a parallel call to action for all drugs. So I don't know that Maryland's Health Information Exchange would be available to folks in other states because of this all drugs law. So, I mean, I'm thinking, you know, the concerns about other providers in other states seeing these data. I wonder if there's any error in that in regard to the statute of sharing all drugs.
Yeah, I think these are the kinds of technical questions we really need to be asking. And I think what we're hearing Maya say is that in the process of selecting a vendor to support this work, these are the kinds of questions that would go into, you know, determining who's capable of doing it. I don't believe in general that CRISP makes electronic health information available to providers in other states unless it's for specific treatment relationship and that provider already in some way through some kind of participation agreements is linked back to CRISP. But Maya, you can correct me if I'm wrong on that. But I think in general, these are the kinds of questions we were hoping you all would kind of bring to light today, because it almost sounds like that out of the gate, we probably have to be thinking about how an NDC level control can be implemented, because the all in, all out is probably not going to work very long term, given what I think we're hearing some of the consumers representatives suggest. And again, you all tell me if I'm wrong, but I think that that I heard Maya and Sarah mention that the vendor are able to block, although it's an onerous list, but it's possibly, we possibly can talk about that at an NDC level. It's just how do you figure out what those NDCs are? I think that's kind of what I'm hearing, the concern that Maya, you were mentioning about NDCs.
Yeah, that's correct. It's really thinking through the technological stuff. I know that oftentimes we're working with regulations and then the technology changes. And so it's how do we kind of make sure that they align in a way that's helpful for both.
Perhaps it's both approaches that have to be thought about initially, depending upon timing. Is, you know, at the early stages, folks are in or they're out, but then what is that progression to having more granular control look like, and you know, how long would that take? I do hear the concern you mentioned, and some of the physicians have noted about, you know, that they're blocking it at an NDC level. You know, things could either be, you know, ruled in that should be ruled out, or vice versa. So it's probably going to require a fair amount of scrutiny by a group of if you will, providers who can look more closely at NDCs if that is in fact the direction that's sought.
David, Dan here, let me just add one other thing for the, just if it's the opt-in, opt-out, I think, and notwithstanding the very good points that Robin Elliott made because of the current political climate, but on mental health drugs, there may be a tendency for people to want to opt out. But I can also say that some of those drugs are pretty powerful and people come into the emergency room with side effects. They can, if they take too many, it can impact their EKGs, cause all kinds of other havoc. So people ought to know that even though there's unfortunately a stigma associated at times, there's also a risk of not reporting. And patients should be fully informed of both the benefits and risks of opting out versus opting in, just to have a complete picture.
And Dr. Morheim, remind me in your experience when a patient has opted out of CRISP, what is it that do you see a flag when you get to the patient listing of all the David Sharps that 3 out of the 10 David Sharps have opted out, or do you don't know that?
I just don't know what happens there. I'd have to, never thought of it quite that way. Maybe Chris can answer, but I can't.
Yeah, and Maya, is that presented through the unified, well, what used to be the unified landing page, now the CRISP portal?
I'm sorry, can you say the question again?
If a consumer opts out of CRISP, what is it that's displayed to the practitioner? Is it that the consumer's opted out, or is it just they don't know? It just doesn't show up.
Good question, actually. I'm not sure. I'll have to look into that.
Kate, I see you have your hand raised. Did you want to add to the conversation?
Yeah, I'll just talk as a person personally affected too. My sister has paranoid schizophrenia. She's been sick for many, many years. When she is doing okay, she sometimes remembers her medications, but when she's not doing okay, she has been in 54 different hospitals over in not only in Maryland, obviously, but in and out. She's doing okay now, but I end up having to try to not only track her down, but then try to get the information to the doctors, by which point often she's already been quite psychotic and in restraints and a whole lot of really not so good stuff. I will also say that were she asked when she was psychotic, she would definitely opt out. But when she's doing better and I can talk to her, then we can have that conversation. So making sure that there's, obviously you're talking about an opt-out that is not in real time. It's a preface thing, but I do want to say that there's a whole lot of stigma. And I do totally get the other political issues. But I hope that with psychiatric medications, we don't have, we do as much as we can to make it possible for doctors to be able to do what they need to. So thanks.
Yeah, thank you. Dr. Paris, did you want to make a comment?
Yes, I did. I had a question in terms of, we have access to patients' hospital records in the office when they come, like as a follow-up. And in that record, you can see what medications they're on as well, whether they were in the emergency room or the hospital. And I'm not sure if a lot of patients are aware of that, but we do have access to records across different hospitals within Maryland that we can see patients' records. I don't know how that would differ than what we're trying to do now, as well as patients knowing that they can opt out. I'm not sure that they're aware of that piece. Sometimes they go to the emergency room. And then I do also have a lot of patients that come to the office and they're wondering why I don't know their medications. They're like, don't you all have something that you connect to or that you can get from other doctors what I'm taking and that sort of thing? So yeah, I think that there's something in place already that we're doing to a certain extent. And then some patients are looking for us to already know some of the information, in my experience.
Mm-hmm. Yeah, no, this is all good feedback. I think that, the issues around granularity of control we're hearing are very important to think through. I I can't imagine us solving this today, but it's good to be able to get the breadth of concerns and the depth of these concerns. So groups like this one can help inform direction. And we definitely think that there's going to need to be some control. We just don't know, is this something that the vendor community, whoever is doing this work, can implement on day one, and what's that level of control look like? Or is it a progression, which is initially perhaps across the spectrum, there has to be better communication to consumers, or it ends up in the consumers about their ability to opt in or opt out and what that really means. And then we look to how there can be some kind of throttling of certain information so it doesn't put consumers in these precarious positions. I think we're hearing that loud and clear. And I think this is something that we should encourage CRISP to consider in developing the request for proposal to identify a technical vendor to implement. Which strategy, how can the strategies be managed or implemented that meets the need of the stakeholder groups here? I think we're hearing from physicians, there's a need to know, but we're also hearing from the consumers that there's apprehension around what it means to have that kind of information or select information shared, and how can that be prevented? I don't know, again, we have the answer today. Well, I'm certain we wouldn't have the answer today, but I think it informs a lot of the work that this group is doing as it moves forward, and perhaps others in the state who are also contemplating this issue. So I just want to ask, is my assessment of what the group is talking about a fair one that we're hearing today? Am I covering all the bases, or am I missing something? And why don't I just start from the consumer perspective? Robin, any thoughts there?
So you're raising a lot of excellent questions that I think we do need to think about, both a short-term, medium, and maybe longer-term solution, and prioritize which issues require short-term solutions.
Thank you. From others from the consumer perspective? Kate, your thoughts?
Yeah, I agree with Robin. I also, I may have misspoken, but when I was giving my description, what happens is my sister may go from one hospital to the next, but she's being treated in the community and getting what she's been on, what she's working, what's worked and what hasn't worked. And then also making sure that the people in the community who are treating her get information. It's all sort of muddy. So I know that there is some sharing, but yeah, protecting confidentiality, not having people lose jobs or other things because of records, but keeping them safe and confidential and used for the right purpose. This is not my area of expertise, but I can talk from personal experience. So thanks.
Yeah, thank you. Anybody else from the consumer's perspective?
So David, I am, although I'm a provider, I'm also obviously a consumer, right? So I have VA healthcare, and I have TRICARE now for life, and I have been farmed out into the community. I can tell you with 100% certainty that none of the three entities talk to each other, and they're all in the state of Maryland. So if I were admitted to a hospital, to a VA or a TRICARE or a community hospital, they would not have my information, and I would have to provide it to them. And so there, I mean, even my vaccinations, my IR in Maryland is telling me that I'm, 47 years overdue for my DTaP. And I've, just had it like 5 years ago at Bethesda Naval Hospital at the, well, now it's called Walter Reed, but do you know what I mean? So all of these systems are in Maryland, and yet they don't talk to each other. So the I'm a consumer that's somewhat educated.
And Dr. McCree, thank you. From the provider's perspective, do you think that this kind of approach that's been on both sides talked a little bit about, this is an appropriate strategy to keep thinking about?
Yeah, you know what, I just think that we're kind of entrenched in what we know, which makes it difficult for us to, and what's paying our bills. And so people, I think, not people, maybe people, but we may be, as humans, we may be reluctant to think about what could be, right? So if we could look ahead to, and NIST, for example, National Institute of Standards and Technology, they just came out with a new privacy policy, right? So again, if we could get, technology companies or technology firms or technology gatekeepers for the state of Maryland, if we could get them to communicate with or to get a update or a primer from NIST, the National Institutes of Standards and Technology, maybe we could move forward and we could simplify this instead of just tacking more stuff on to what we already have to do. So as a provider, I don't want to do more stuff, right? So now you're making me have to look to see if somebody has opted in or out, right? And so if somebody's opted in or opted out, then I just have to assume that I know nothing about that patient, right? And then on the other hand, because I too am affected as a provider by the the current climate, right? Then I have to fear not only for my patient, but I have to think of all the places that I've seen my home address and phone number on the internet. And then I have to worry about whether some of these crazy people, these non-Christian people that claim that they are will come to knocking on my door, with their illegal firearms. I mean, these are the things that we all did. But if we look at the new standards and maybe try to not just incorporate them, but move to the next level of technology in healthcare, maybe we can streamline and maybe we can make it easier for the dispensers, the prescribers, and the consumers.
Yeah, very well put. I think
I just wanted to say one thing. Sorry.
No, go ahead.
Before, I know we're running out of time, because these are all issues that are not necessarily specific to medications, and I do think it's an important conversation. But I just want to reiterate that CRISP is working on creating a structure for this outside of medications, and so I think it's kind of a separate but related conversation. But I want to be clear that our focus for this will be on creating what works for the medication side as we continue to think about how folks can consent and opt in and opt out.
Yeah, and thank you, Maya. And CRISP has done a phenomenal job in the years since they've been providing HIE services in Maryland. And I'm certain that this too will be an issue that we do get to the other side of at some point. But everybody's comments add value and perspective, and we're greatly appreciative of that. So we've hit up against the hour block. Let's just sort of, Anna, where do you want to take us in the next minute or two before we need to break?
I definitely want to thank everyone for your contribution for today's conversations. It's been really wonderful. Before we jump off, Maya, do you have any additional updates to share from CRISP about the implementation of this bill?
Well, we are happy to be working on this project with you all, and we are anticipating that we'll be able to release an RFP in the next 45 days or so, obviously subject to caveats, and I will let you know if that changes, but that is something to look out for, and it will be publicly available when it is ready.
Okay, thank you. Anna, back to you.
Wonderful. Thank you, Maya. We do not have a date scheduled yet for the next meeting, but we will be in touch with everyone regarding that next date. And before we wrap up, I don't know, David, if there's any closing words that you'd like to share with the group.
No, I would just thank everyone for their input today. It's so amazingly important to hear your voices. We thank all the perspectives of the contributors today, and those who didn't say anything, we're equally as pleased that you're here, because my suspicion is that you agree with what you heard, and if you don't, we encourage you to let us know. So we just want to make sure everyone gets a chance to be heard and that we've thought through as best we can all the points and issues made. So thank you. I suspect more to come on this.
Great. Thank you, everyone. Have a good rest of your day.